You're watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. Today's topic, hot topic, mommy makeovers. With us, we have an expert on the topic, Dr. Winslow. Dr. Winslow, welcome to the program.
Thank you.
Now, before we get into today's topic, tell me a little bit about your practice. I guess it's in Sacramento, Cameron Park, on natural plastic surgery.
My practice is universal. That is, it extends from cleft lip, palate, burns, congenital anomalies, cosmetic, hand.
Okay, on to today's topic, mommy makeovers. What defines it?
Those are mothers who have finished having their children and perhaps nursed them. They've gained a little too much weight and haven't lost it all and can't get rid of it by exercise and diet, and they're sort of discouraged. And they come in with stretch marks and sagging of their breasts, and they're too small, and they can't wear clothes. They're self-conscious, and they're ready for a new life.
Let's begin with breast lifting. And let's talk a little bit about technique. At what point does somebody need a lift, by the way?
Well, there's certain standard measurements that are normal. For example, the distance from here to the nipple should be 18 centimeters, maybe 20 in a slightly older patient, but not 24 or 30. So it depends on the measurement. And then it has to be lifted by the amount that will bring the nipple to this point, bring that distance down to 20, let us say.
Okay. Now, do you go over the muscle, under the muscle? Let's start there, and then I have questions about incisions, where you place the incisions, things like that.
Well, when you're talking about over or under, you're talking about the pectoralis muscle, which is this one.
Okay.
And I always go under, unless there are extraordinary circumstances, one of which could be patient request. But I recommend going under the muscle because a thicker covering gives you a softer result.
So incisions, where do you place your incisions?
Well, in many ways you can place them. You can place them in the armpit, you can place them in the nipple or around the nipple, on the bottom of the breast.
Like in the fold?
Yes.
Okay.
Or even through the belly button, but I don't like any of them. And so I make mine on the bottom of the breast, not in the fold, above the fold.
Interesting. Okay, so not in the crease at the bottom of the breast. I mean, would that be the best place to hide it?
Well, yes, except the underwire of the bra tends to rub there, and then you have a problem with can have a problem with the scar.
Okay.
So I like it up a little bit from there, maybe an inch or half an inch above that line. Now, I was originally taught to do it that way, and then I tried the transaxillary, the transareolar, the periareolar, even the belly button, and they're all too difficult, too complicated. They slow the procedure down, and I think it's important that the simplest thing is the best thing.
Does it give the best result, though, as far as natural-looking breasts?
Absolutely, because the problem in breast enlargement is right here, where the serratus muscle, which is coming between the ribs, and the pectoralis meet, and they interdigitate.
Okay.
And there's fascia. Fascia is the tight tissue that binds all muscles. And if you cut the fascia, the muscle will bulge through. So you don't want to do that. But down here, you have to have fascia to support the weight of the breast. That is what makes the whole operation submuscular.
Okay.
Because the pectoralis doesn't come down to the lower third of the implant. So you've got to have something to cover the lower third, and that's the serratus fascia.
Okay. Now, the nipple. You know, I've had doctors come on the show and say that it gives you more control of the pocket. It's easier placement of the implant. What are your thoughts?
I think those are all true statements, but that misstates the case. First of all, the scar around the nipple can be unattractive.
Okay.
Second, it may interfere with sensation to the nipple more than any other incision, which is important.
Okay.
And there's an even a better variation. Instead of going around the nipple, you can go through the nipple.
Interesting.
You have the same exposure. The scar is invisible, and there's no interference with sensation since the nerves come around this way, and your incision would be going between the nerves, not across them. But nobody likes a scar in the nipple. The nipple's a beautiful thing.
But it's being done all the time.
Should be left alone.
Yeah, no, I agree. and I think most people would agree that if that's the most beautiful part of the breast, why go through there?
Right.
So you rarely then go through the nipple area.
Almost never. And I never go through the axilla anymore either. When I did that, I found there was a tendency to cheat, which by that...
What does that mean? Yeah.
That means making the incision a little longer or lowering it from the dome of the axilla where it's supposed to be down onto the chest wall in order to get an implant in, especially a gel, which is very difficult to do through the axilla.
Okay.
So I don't do that. And I think the inframammary is the best of all of them. It heals beautifully.
Underneath?
Yes, right.
Okay. So what's your take then? Is it, and you're doing it because the best results, looking results.
I think so.
So and I'm trying to get this. So is your opinion though that doctors who go through the nipple area, it's just an easier shortcut, easier procedure for them to do?
No, I think it's a good way to do it. I've done it that way, and I will do that if the patient wants, but I don't always like the scar.
All right.
And I definitely don't like a patient who complains about lack of sensation as a result of the surgery.
So do most of these women, I mean, do they tell you that they've been thinking about it for years and years and years? They haven't liked their breasts for years and years and years, and they've just been afraid to do something about it?
Well, yes, but even to the point of not wearing bathing suits or being seen out in public, it's with them all the time.
So what is the biggest fear then? Because there's a lot of women obviously that want to lift, but they're afraid.
Well, probably the scars. But I have an example in the office of someone who's had this done, and at that point I show them that patient where you can hardly see the scars at all, and
Okay.
that's very reassuring. Let me tell you the story. My wife and I went to a little shop in the mall, and she tried on a dress which fit beautifully. But while we were there were a bunch of girls looking for debutante gowns, and they were all complaining about the fact that the gowns didn't fit on their top.
Okay.
And they couldn't find anything that worked. And I kept wanting to say, can't I go up and tell them something can be done about that? They can feel good about themselves instead of so negative.
Now, what are the frequently asked questions on the consult of this mommy makeover? And by the way, if you're just tuning in, we're talking about mommy makeovers today, tummy tucks and breast lifting, so and also augmentation. But what are the frequently asked questions?
Well, there are two.
Okay.
One is the scar, and second is the nipple. And everything else falls into easy answers beyond that.
So with determining size on a lifting procedure, and not all of these people are, I guess, are getting implants on the lift.
That's correct. There are 3 or 4 kinds of breast problems other than being too small. One is a sagging breast that is too small. That requires an implant. The second is a normal-sized breast that requires a lift only. The third is a breast that's too big and sags.
Okay.
And the fourth is one that's too big and doesn't sag. So each of those has to be handled differently.
So with the one, after pregnancy, they've lost volume, maybe very little breast tissue at all, and they need an augmentation. How do you determine size? What's that process?
That's an interesting process because we have a lot of implants in the office that are samples.
Okay.
And we have bras, and we put them on the patient and put in implants, and then they put clothes on and look in the mirror. And we want to get a balance between the breasts and the buttocks. They have to offset or balance each other in order to look good.
Interesting. Tell me about that. What do you mean?
The sizing is done with a mirror and the patient looking at her profile. And we go up in size beyond what I think might be all right. We push it until the patient is revolted.
Okay, where they're too big. Okay.
Right. So, whoa, that's way too big. And then we back off until the patient says, that's pretty good. Now, the patients are usually shocked
Why are
because
they
they're so
shocked?
surprised. And they, cover their
Like,
faces.
what are they surprised about? Just how good they
the
look? you're
weight.
saying? Oh, okay.
And the whole thing, they say, this is what I always wanted. I can't believe it. And sometimes they get too frightened and they back off and they don't go quite large enough. But basically, it's much more successful than what we used to do, which was nothing except guess. And that's when people would come back and say, well, I wish I'd gone larger. And many people did that. I haven't seen a patient do that
Really?
in a year or
Does
many
that happen?
years.
Of the two, that they should have gone larger or should have gone smaller, which one is the biggest complaint?
They didn't go big enough.
Is that right?
Yeah.
Do you tell them that?
Well, they tell me that when they come in post-op. I wish I'd gone larger.
Right, but do you tell them, I mean, on the initial consult that you know, you got to make sure you go big enough so you have no regrets?
Yes, but we have two opinions here. We have theirs and mine.
All right.
Now, if the two are the same, then we're pretty happy. If they're different, then we have to resolve that conflict.